Hello, everybody. I'm Duncan Turner, and you're listening to the Vagina Doctor Podcast, Episode 2. Today, we're talking to Oncology Specialist Dr. Julie Taguchi. Julie and I have been friends and colleagues for a number of years, always, it seems, talking about hormones and breast cancer. This is a great episode if you have questions and concerns regarding this, and you've been following the recent news from the Women's Health Initiative. There's a lot of false information and concerns regarding hormones and breast cancer. I think you'll get a lot out of this. Please enjoy the episode. But what do I know? I'm just a vagina doctor. Today I have Dr. Julie Taguchi with me, who's been a friend for a long time. It's a privilege to have you here with us.
Thank you.
And also listening in is my partner, Karen Spaulding, who will be here to keep us on the straight and narrow and perhaps pull us down a peg or two in terms of talking about things in a sensible, understanding way for our listeners. Julie, as I say, welcome. We go back before our medicine time together because I coached your son at soccer when he was 12. I think he's 30 now, so we've gone back a way. But what pulled us together was, in my understanding, is when we were talking about hormone replacement therapy and with our mutual friends and talking about the book that you co-authored, Sex, Lies, and Menopause. You're board certified in internal medicine. You're by subspecialty hematology oncology. After doing those degrees and that training, you worked at the City of Hope for a couple of years, and you've been in Santa Barbara since that time. Really focusing on breast cancer and the association between breast cancer and hormone replacement therapy, or lack thereof. Everybody that we invite to this podcast is, to me, remarkable in one way or another. And I would really describe you as remarkable because you've pushed the boundaries, you've challenged the status quo, you've been the first oncologist that I know about that's even considered hormone replacement therapy in patients with breast cancer. And it's really, I don't want to be too critical of all the other oncologists in the world, but when I have approached oncologists about hormone replacement therapy in patients with breast cancer, even though I'm talking about perhaps just using it vaginally, there's very little interest. I mean, it seems to me that the oncologist the primary focus is keeping somebody alive. And I think sometimes the quality of life issue gets neglected. And when I can get excited about various procedures that we have for symptoms that women that have had breast cancer that are unable to take estrogen or are on anti-estrogen meds, and they're miserable, and I'm trying to help that, I've found very little enthusiasm or assistance from oncologists in that. And so I want today for our listeners to hear your opinion of hormone replacement therapy in various types of cancer, why the population and the medical population as well have been somewhat opposed or completely opposed without good reason. And it's the one thing that occurs to me is that in about 1900 there was a study done at one of the hospitals in London that looked at the first 100 patients that came through what's called the casualty department of the hospitals there, but basically the emergency room. And they collected the cases of 100 people who came through the front door complaining of chest pain and died. And they did autopsies on all of them. And because 98 of those 100 patients were male, it was felt and believed at that time that women didn't get heart attacks. And it's taken 100 years or so to change that thinking. And one of the things that we'll talk about today is the Women's Health Initiative study, which looks at the use of hormone replacement therapy in postmenopausal women being stopped because of complications that were interpreted, at least at that point. And now estrogen suddenly is the bad word, the dirty word. And so many people just think that hormone replacement therapy of any type, whether the patient has breast cancer or not, is the wrong thing to do. And we've been struggling with that because we can really improve health and quality of life for women with the appropriate use of hormone replacement therapy. Tell me your story. When did you first start to think about challenging this issue, or do you challenge it?
Well, first of all, thank you for having me here in the introduction. So what was really interesting is it was my introduction to Susie Wyle that made me think and made me change. So Susie Wyle is the co-author of the book Sex, Lies, and Menopause, and she lived in Santa Barbara.
Yes.
And one day she showed up in my office with a stack of papers on how progesterone can cure cancer. And she wanted me to know that my patient, who was a 90-year-old man from Louisiana, who had cardiomyopathy, neuropathy, he had every apathy that we could list. And I knew he was my patient. I mean, as my patient, I knew he also had transitional cell cancer of the ureteral lining. And he had come to California to live with his daughter. And when I saw him, he had his second relapse of metastatic disease. And he didn't want any more treatment or chemotherapy, and he had lung mets as part of that. And so we put him on hospice, and every month I'd have to go check on him and all that kind of stuff. But Susie Wyle came to my office and said, I just want you to know I put your patient on a boatload of progesterone. And I'm like, what? And this is a man on progesterone. And so she said, yeah, it kills cancer cells. And I said, okay.
And let's throw in the fact here that Susie is an anthropologist, correct? She's not a physician.
She has no medical background.
No medical background. She's just brilliant.
She's just brilliant, but she had done research. She had done clinical, she had done bench research. So, and she had published before I met her. So anyway, so she presents this, and I go, well, my patient happened to be a physician. So I said, he can write for his own progesterone. I will support that. He's on hospice. Whatever he feels comfortable, I will support. And literally like 9 months later, he was still alive. We got a chest x-ray, and the chest x-ray was clear.
Wow.
Yeah, that was the wow. That was the wow moment for me.
Yeah.
So I said, okay, what happened? And then I went to talk to my oncology colleagues. Like, oh, he probably had prostate cancer. Oh, he probably, this, that, all these answers that didn't make any sense.
Yeah.
And so that's when I started really being interested in the research for the hormones. And then I started studying compounded hormones, and I studied the rhythm of hormones. Now, along at the same time, I was an oncologist, or I am an oncologist, and one of the things that, this just the standard of care is that all women who have estrogen receptor positive breast cancer will be recommended to have an anti-estrogen therapy for anywhere from 5 to 10 years, no matter what their risk is. And it'll be everybody all the time. Okay. Yeah. Even if you're 90 years old, I'm kidding. I just had a 90-year-old who was just told to be on anti-estrogen therapies for a stage 2 lobular, had a mastectomy, and she's like 90, she's 93. Wow. And I'm like, oh my gosh, please don't take anything. And she's not, but I have a relationship with her. So, but I had all these patients in my clinic who were, breast cancer. They're on either tamoxifen or some AI. And of course, those drugs they're basically, we castrate women.
Yes.
We castrate them. And when I say it like that, people go, what? Yes, that's what we're doing. We're castrating. We're shutting down the estrogen, either the production or the body's ability to see it. And so women, when they don't have hormones, they have a lot of other effects, right? They can have the brain fog. They can't sleep at night. They get depressed. They have vaginal dryness. They have, their skin itches. They're not potentially not very happy people. And a lot of women in my practice were single, and they were having hard times working and all this kind of stuff. And they would say, you know what? Why do I feel so terrible? Why is it like this? I said, oh, well, you're depressed from the medication, or you have osteoporosis from the medication. You're not sleeping because of the tamoxifen or AI. And we have drugs for that. We have drugs to help counter all of that stuff. And then people would go, you know what? I don't want that.
Right.
And they were making personal choices. Like, you know what? Why am I like that? And it's because you don't. I said, it's because you don't have your estrogen. And they go, well, I want my estrogen back. And then we're back to, well, the standard of care dictates that we need to castrate you for 5 years. Yeah. And they're like going, oh, I don't want to even live like this. I don't want to live like this.
Right.
What's the point? And that's where another aha moment for me was, why shouldn't these women have a say-so whether they take the medication, and what about taking hormone replacement? There's one thing to stop the medication, but then there's the next step going, well, now I want my hormones back. I want them back.
Yeah.
And I said, well, they're not going to be back in the way that they were when you first started the medication. But hormone replacement could do that. And that's where I started having the conversations with the women for quality of life. I will support you for quality of life, because I can't judge that for you. But you have to understand what the risks are by not taking the drugs. And if you take the drugs, what could happen? So I would walk women through these different scenarios.
Something like informed consent.
Major informed consent. And if they wanted to take that if they took the responsibility, because I put it on them. Yeah. You're making the decision to take hormone replacement. And I said I would support you as long as you hear me out, and I will support you on that. And that's what happened. I started giving women the hormones back. Their lives changed drastically, like night and day. And people were like in bed with severe arthritis and depression to being ballroom dancers and competing in the next year. So, really drastic.
Yeah.
So it was exciting to see that. And they had a life.
Yeah.
And then other women started to have, they were dating, they were having sex because they felt the desire.
Right.
So it changed people's lives.
My first connection with Susie was almost the same way, that she came knocking on the door with a wad of papers under her arm. And I, at that time, had just been diagnosed with prostate cancer. And I was looking at, in the traditional way, at surgery. And being a surgeon, that's kind of what you do. It's one, you just have to do it if that's the way to do it. But she came up with this idea, well, really, we don't want men with prostate cancer or we're told that men with prostate cancer can't take testosterone, but why not? And why are we saying that that testosterone causes this when young men who have way more testosterone than 60, 70, 80-year-old guys, but it's the 60, 70, 80-year-olds that are getting prostate cancer. And so she started talking to me about that. So that's what opened my eyes to it, and it's how we communicated. But then it was getting in touch with a compounding pharmacy that was making bioidentical hormone preparations, which made this available. And the rhythm that Susie was suggesting of what was termed the Wyle protocol, which I want to talk about in a moment, but it was that got me interested in it. Add to that my patients being in practice at that time for a little over 20 years in Santa Barbara, 2002, it was 24 years or so. The patients I delivered were now, the patients whose babies I delivered were now perimenopausal and menopausal and were needing treatment, and I needed more information about it. And that's why I latched onto you, because it was to have somebody of your intellect and experience and knowledge there supporting what a few of us around the country were doing. Now lots, but still not the majority. It was really helpful. So I have Susie to thank for that, for sure.
Wait, I want to say something.
Yeah.
Let's just go in briefly to the Wyle protocol, because I'm sure maybe some of our listeners are Googling Wyle protocol right now. So let's
Yeah.
explain that. What is that?
Julie was very much involved with the development of that, but I could put, not the development. Okay. So I should maybe more accurate say you were aware of what Susie was suggesting. And it sort of made sense in lots of ways that Susie Wyle, the co-author of the book, was looking at women in their reproductive years as being at their strongest in terms of fighting infection, fighting cancer, just at their healthiest. So if she could put those women back into the hormonal rhythm of a menstrual cycle, that must be better for them. Is that an oversimplification?
It's good.
Okay.
She wanted to, when women are healthiest and their optimal health is in their like 20s, 30s.
Yeah.
When they're reproductive.
Right.
And when we replace hormones, by the way, let me start over again. She took that model. Postmenopausal women don't have hormones, right?
Right.
It's very dribbling, if any. So there's nothing. So that's the natural normal state.
Yeah.
When we replace hormones in general, like if we did insulin or thyroid hormone, we don't just give them a little bit and let them go on. We actually measure levels. We want it to be therapeutic and physiologic. And so for all hormones,
Yeah.
right?
Yeah.
So why not the same for estrogen and progesterone and testosterone? So that was her thinking.
Yes.
She's like, why shouldn't they be replaced in the way they were meant to be replaced?
Right.
And so, and of course, I had no hormone replacement therapy background when I met her. And it was like, well, of course that makes total sense.
Yeah.
Right.
Right? So anyway, and I went with that. And
Yeah.
Anyway.
One of the few things that patients didn't like about the Wyle protocol was that if you did it the way that Susie wanted you to take it, it would be a full-blown period every month. And a lot of patients didn't want to do that again.
That's correct. But that when you were optimal, healthy, and reproductive, you had a full-blown period.
Right.
So that's the trade-off.
So, and I don't know what's happened to Susie.
Oh, I just saw her.
Oh, you did?
Yeah, she was just here in Santa Barbara.
Oh, wow.
Week. Yeah.
Okay. So, obviously we both had significant connection with her, but let's go into the whole, the evaluation of the Women's Health Initiative study. Explain for our listeners what that was, why it was stopped, and why so many parts of it being stopped, or so many reasons were incorrect or misinterpreted.
Okay, so the Women's Health Initiative, everybody should know that term by now, I hope. It was a study that was started in the 90s, and it was a prevention study, hormone replacement to see if it helps prevent, like cardiovascular disease was the main focus. So they had two different studies. One was women who had a uterus. They were they were randomized, right? The computer made the choice whether they received hormone replacement therapy, which was with Prempro, a drug which is a combination of Premarin, which is the pregnant mare's urine, and
An estrogen.
which is an estrogen, thank you, and then medroxyprogesterone acetate, which is a progestin. It's a drug with hormone effects, but it's not a hormone. And then versus the placebo. And in that study, there were like 8,000 plus women in each arm. And if a woman didn't have a uterus, then she was randomized to Premarin alone, estrogen alone, or placebo. And there were about 5,000 in that study. Total, that the whole group was at 17,000 women. So it's a big study, and it was really great to have that many numbers because it really gave us some good data. It maybe led us in the wrong direction for a while, but it gave good data for us. So, and of course, the women entered in the study were ages 50 to 79. So they started hormone replacement at that. There were some women who were on it previously, but maybe beforehand, and there was a washout. but it was like less than 25% of those women. So they were trying to look for cardiovascular benefit, but they also at that time in the 90s, were associating hormone replacement therapy with breast cancer as the biggest signal of an adverse event. And so what happened about 5.5 years into the Women's Health Initiative, they got a safety signal on breast cancer. So the women who had a uterus, who were in the Prem-Pro or the estrogen progestin group, had more breast cancers diagnosed within that first 5 years compared to the placebo. And because that was the biggest safety signal, they stopped the study 3 years early. Mm-hmm. So, but in the other group, with the women on the Premarin or the estrogen alone, that continued because that signal of breast cancer wasn't there.
Right.
So that was completed. And they found out, which is really important because nobody wants to admit this, that there was a 23% risk reduction of breast cancer in that group. And it held 10 years, and it's been almost 20 years now that reduction risk has held. Now, mind you, they only received it for 6-something years, whatever, but it lowered their risk of breast cancer.
Isn't it safe to say that estrogen has never been shown to be put somebody at increased risk for breast cancer?
No, I can't say that because I can't say that. I think there's the nurses study, which is an older study. It was an observational study, though. Mm-hmm. Women who were on the Premarin alone at 15 and 20 years did show a slightly increased risk of breast cancer, but I want to say it's the garden variety, low risk ductal, mm-hmm. Highly ERPR cancer that probably wasn't going to kill anybody in an older woman.
Right.
So there is probably something, and maybe it's because they had all 20 years of the conjugated estrogen without progesterone.
Right.
And was that isn't a bioidentical?
Correct. It's not a bioidentical. Actually, we should probably define
Yes.
bioidentical.
Yes. Good idea.
Bioidentical. So the term bioidentical really was coined by Suzanne Summers when her book, The Sexy Years, came out, and she had been on bioidentical hormones for a while. And what it basically is, bioidentical basically means like estradiol, human. It's a human molecule. It looks like a human
Same molecule.
Mm-hmm. Yeah. It can start out as a plant, like soy or yam, and then the side groups are clipped so that it looks like a human molecule. It's not truly bioidentical because the term bioidentical would mean that we put the gene in a bacteria that says make all this estradiol, and it would crank out estradiol, and that would be a bioidentical product.
Right.
So it's kind of a misnomer. It's really a human identical hormone replacement is probably the best way to put it. But anyway, we use estrogen or estradiol, sometimes estriol, estrone, or actually we don't use estrone anymore. Testosterone and progesterone are can be compounded into these hormones. But there are FDA products that are that are bioidentical, right?
Right, yeah.
So the patches and gels. And
mm-hmm.
the oral progesterone, those are all FDA approved bioidentical hormones.
Right. The figure, the names, the adjectives, I suppose, that are thrown around are natural. Well, a lot of patients think natural is something that is plant-based. And yes, a lot of these are plant-based, but they're plant-based and then manipulated.
Synthesized,
mm-hmm. Exactly. So it's not necessarily natural, but it is the other term that's thrown around is compounded, as the other dirty word that's thrown around is compounded, because for a long time the pharmaceutical companies were not making anything that was a bioidentical product because it wasn't in their best interest. There wasn't any money to be made out of it.
You can't patent.
They can't patent it.
Yeah, a natural substance.
And the only reason I think that they got into it at all was because they could patent delivery systems.
Correct.
Which are the patches.
Mm-hmm. Patches.
And that was
gels.
great because the transdermal approach is, as we know, we believe, is the safest way to
we know.
administer. We
Absolutely.
know. Yeah.
We know.
So the natural, the bioidentical, the compounded all need to be understood by the listeners as for what they really are. And estrogen is not really being so much the problem child. It's more the progestogen that was.
So thank you. So that was something that needs to be pointed out by the Women's Health Initiative, that it looked like the estrogen really was okay, but the progestin was a problem.
Right.
And so I think that's actually turned the corner on making estrogen maybe not as bad, not the bad guy.
Right.
Now they think it's the progestins. And the problem is a lot of people use progesterone. They include that in the progestins.
Right.
So they think progesterone's bad. So I think that's not warranted, but that's what people do.
Well, but the progestins will compete in the body for the progesterone receptor.
Well, yeah, but they're not progesterone. They don't.
No, they're not progesterone.
Yeah, right.
They actually block the
Yeah.
use of progesterone, block the body's efforts of making the rest of the progesterone. So they're competing in that regard. Thank you. It's really, let's talk a little bit about the use of hormone replacement therapy in patients with breast cancer and the various types of breast cancer, basically hormone receptive or not, and what are the dangers, or what's a reasonable way? The way you described earlier, which is informed consent for patients because they were miserable. Either the medication was making them miserable or they were just miserable because of the lack of HRT, which they had been having previously. When is it okay, or what particular ones do you need to be concerned about? I mean, if a breast cancer has no estrogen or progesterone receptors, is not sensitive to those drugs, is there any problem in giving hormone replacement therapy to them?
So for the women who are diagnosed with, we call it triple negative breast cancer,
Yeah.
there is, in my opinion, in my experience, absolutely no problem. As a matter of fact, I think hormone replacement with the Wyle protocol is very beneficial. I have about 11 women that I've treated, and all those 11 women are alive and well. And I'm going to tell you, 2 of them didn't even have chemotherapy.
Wow.
Wow.
So and I think when like the Wyle protocol, or the the rhythmic dosing, or the even physiological restoration, whatever you want to call it, it's trying to hit those same hormone patterns and trying to make things normal, regulate normal cycling, because the breast tissue cycles like the uterus cycles and all that. So I think it's trying to restore some normalcy in the triple negatives, with people with triple negatives. So that to me was shocking.
Yeah.
I mean, and so I personally have zero concern about somebody with triple negative breast cancer. Also,
What does that mean, though, triple negative?
that's a good question. Thank you. Triple negative. Okay, so when we do a breast cancer evaluation, we, like if someone had a mass, we send it to like radiology to have a biopsy, and that biopsy we have some standard data that we have to obtain. Does this tumor have estrogen receptors? Yes or no, or positive or negative? Do they have progesterone receptors? Positive or negative? Do they have androgen receptors, which is a new one, positive or negative? There's something called a Ki-67, which is a proliferative index. How fast is this tumor growing? And another marker called HER2, which is a protein found in about 20% of breast cancers that implies more aggressive disease. And we have lots of treatments for it now, so very treatable. So we have this minimum amount of data that we get. So if the tumor does not express any estrogen, progesterone, or HER2 receptors or proteins, that's considered triple negative.
Okay.
So they should not be affected by taking estrogen or progesterone.
Yeah, thank you for the clarification.
And then if a woman has not been getting a period, let's say she gets a diagnosis where you could use with the Wyle protocol, then she just starts getting a period again. It's like her body picks up where it left off before menopause?
It may take a couple cycles, but yes, for the most part.
Because you're still getting the hormonal stimulation of the endometrium, the lining tissue of the uterus, which is what sheds and causes bleeding once a month in a menstrual cycle.
And just to take this a little bit further, what's really important about the cycling, I said the breast tissue cycles, the bone cycles, and it follows the same rhythm of the hormone pattern, so the body uses its own rhythm for many different things in the body. Okay, it's really fascinating. So the cycling part is important, and even the data that's out there for hormone replacement, cycling is better than, we'll call it the continuous combine, which is taking another option of hormone replacement of taking both estrogen and progesterone at the same time every day. So the cycling, seems to be a bit better in terms of results for like osteoporosis, cardiovascular, et cetera.
We were talking recently, and you said that the body does so much better with estrogen on its own for a while. I mean, that half of the cycle. That really stimulated my thinking. But what do you mean by that?
Well, it's just, looking at the reproductive cycle, the first 2 weeks are really estrogen alone.
Right.
And then there's that day 12, 11, 12 peak where it's just
Sky high.
just for a day. And just, normal, I'm just giving you some references, like in our lab work here, it's like 350 to 500 is like peak ovulatory rate.
Yeah.
Well, I had measured my sister's day 12 when she was 40, and it was 700. And that was her normal, 700. So, nobody would think anything of that, right? Nobody would draw it. I just drew it because it was day 12 on her, and I wanted to see what it was. And there it was. But the point is that day 12 is really, really high, but it signals when that spikes up like that, it's like a transmitter to tell the rest of the body, hey,
there may be a pregnancy coming.
There may be. So get ready. Make testosterone receptors because we want to use the egg we're going to pop. You better make more thyroid receptors because we have to get ready for pregnancy. We need to make, the right progesterone receptors. Not just progesterone receptors, the right ones. And we need to make more estrogen receptors. So that's what the day 12 spike does, okay? So that's about the doing the rhythmic dosing, but that first 2 weeks is all about estrogen and prepping the body for that. Right. Then there's the on button, and there's the progesterone added the second half, which is, I call it the off button or the cleaning the slate when they do during that period of time. Yeah. And there's a yin and a yang. So even high doses of estradiol, by the way, on day 12, which activates P53. Okay, P53 is activated, so you have less cancer problems.
Yeah, right.
It's just incredible.
So, what's your ideal way of replacing hormones for a postmenopausal patient?
So, I think we have to go back to timing as to what age are we talking about.
Let's deal with 50 to 60. 50
to 60. So, and the reason why I say aging, because if they're closer to menopause, I really think if they're perimenopausal or closer to menopause, when they started, I do like the rhythmic dosing. I think that is really beneficial. But of course, it goes back to having the conversation with the person, because they're going to say, there's no way in hell that I'm going to have another period in my life.
Right,
Sorry.
exactly.
Sorry. And I said, okay, well then, you can only get so far, and maybe your health, or if you just want to do symptom management, it doesn't take very much estrogen to cover a hot flash.
No, it doesn't.
So if that's what you're looking at, then that's what.
But one other interesting thing to me that I've discovered through a lot of the procedures that we have now for genital urinary syndrome and menopause, got a name in 2014, been there for millennia before that, but was a combination of a number of symptoms of urinary frequency, nocturia, having to get up out of bed and pee at night, not being able to go and sit through a movie or have more than a 2-hour car ride. And then, of course, incontinence, whether it's stress incontinence, when a woman is leaking urine when she coughs or sneezes, as opposed to just leaking because they have urgency and they can't hold it. Those patients, we have since 2016 these new treatments of vaginal rejuvenation, which work like any other rejuvenation procedure on the body. A little bit of damage by a laser or radiofrequency, electricity and heat, starting a healing process with the increased blood supply, increased collagen being beneficial. Those patients do better when patients are on estrogen.
Of course.
But the levels that we get to with the systemic estrogen, maybe 70 picograms, 100 picograms, something like that, that's often not enough for the vagina. And they need a boost in the vagina, even though it may be 1% of the systemic dose, just micrograms. It's I found that's necessary as well. So the vagina itself, really bring it back to my specialty, really needs that extra boost. And again, we run into insurance companies then who only want to use Premarin cream. So, but what you're telling me is that maybe Premarin isn't so bad after all.
Well, at least orally in the study.
Yeah. Right.
But see, this is where compounding, if people don't understand the definition of compounding is basically a specialty, a pharmacy that will make the product in their own lab.
Yeah.
And so it's kind of like cooking, and I'd like to have one order of estradiol cream for the vagina, please. They can do it for much less than what the than what we pay for to the drug company.
Right, absolutely.
And so
I have lots of patients doing that.
Yeah, so we have ways around it.
Yeah.
Of course, I want you to know that the FDA is trying to get rid of the
Yes.
compounding pharmacies,
Absolutely.
right? So because they're competing with drug companies.
Right.
So please, everybody, don't let that
All
happen.
the listeners out there.
Yes.
Yes.
We have to say
Compounding pharmacies are necessary.
absolutely it's necessary. But there's no FDA approved testosterone replacement for women. None.
Right.
So
Yeah.
important.
And if we're using it as a compounded, it's a controlled drug, which is just ridiculous.
You're correct.
We have a lot of women abusing testosterone.
So it's anyway, it's nuts. That would be my one political charge. I would go to Congress and say, just give up owning testosterone and growth hormone. You guys don't need to be bothered with that.
Yeah, right.
Leave it to the doctors. It's silly. Under congressional control.
Yes, absolutely. I think I'm almost out of questions for you. Not quite. I have one more, but Karen, do you have anything else you want to add? Or
just to say,
actually, I have two things.
Okay.
Three things.
We have patients that we're dealing with in the office that they've had a breast cancer diagnosis, and they're more upset about stopping their hormones
Absolutely.
Yes.
than they are about the diagnosis. And the panic that comes through with that diagnosis, even for me, when I see those come through the office, it's very, I'm very sensitive and upset about it. And these are patients we've been seeing for a long time. And then, they're very frantic about the hormones and what to do. What do I do? I think I'd rather just stay on my hormone replacement therapy and have a shorter life. And that's,
Yes.
Absolutely.
got
lots of patients like that.
yeah, that I want my quality of life. I don't want that to change. So, it's fascinating to me that, that we women do think they have to choose one or the other.
Well, they do have to choose, because if they're in the oncology world, right, if they're in the oncology world with a relapse, they do have to choose, because they will be told to stop their hormones if they have an estrogen receptor positive tumor.
Yeah.
And that's based on the theory that the estrogen fuels that growth. So, and the dirty little secret is like that, it's not that the estrogen, that tumor was always there. So people think, the cancer went away and came back.
Right.
That whole concept. No, the cancer just never left.
Yeah.
And
Right.
so and that's the part of the counseling that I do. Even 30% of all stage 1 cancers will relapse in 10 years.
Yeah.
So we know that even at the time of diagnosis, they're going to have some sort of disease spread. But anyway, that's part of the informed consent that I have. And you're right, a lot of women don't want to stop their hormones. They're freaked out about it because they're living well and they know what it's like to live without it.
Right.
And I think we're back to, these are grown-up women. They can, have a choice on how they
can
want
make a decision for themselves.
Yes. They should
Right.
get the information and make a decision.
Yeah, it's that whole idea of informed consent, I think, is really interesting, because not just in the hormone replacement therapy is one arena that it comes up, but patients. I've been criticized by colleagues in the past because I did a myomectomy on a patient. I removed fibroid tumors from the uterus because she didn't want to have a hysterectomy. She was, let's say, 50. And I was criticized for not insisting that patient have a hysterectomy.
Oh, I'm sorry.
And it's just, I mean, the ignoring what a patient wants is, or what their personal opinion, their personal preference is malpractice, in my opinion. It's just wrong.
Well, that person would have found a doctor who would have done it somewhere because they had a belief about, they really wanted to keep their uterus,
right.
and it was super important to them on a mental, emotional, or other
Absolutely.
level.
Yeah.
And so I totally understand where you're coming from. That's compassion.
Right. And it's the patients are not listened to very much.
Yeah.
And I think that's what you said when we've talked previously, that you listen to patients, you pay attention to, you want their side of the story. It's not just one way that's going to work, that we have to go on the particular protocol.
I like your answer to one of our questions of, you're the person who, and you said you're accused of having ADD. Because you keep going with things and you are, wanting to get to the answer. But how does that affect your household? That type of the way
My house is a mess.
So they're right.
Well, no, I do this thing where I think I drive everyone in my house crazy because I'm similar in that I have to be busy all the time. And I'm just that person that has to be, I don't know why. It's probably some underlying anxiety that's never been diagnosed. Who knows? But it's just the way I am. But I think it drives everyone crazy.
Well, I'm just curious.
Yeah.
For me, it's curiosity. It's like, it's like I'm the why person. And I want to know why. And so that leads me down to a bunch of different rabbit holes because of, just asking those questions.
Right.
So, I've had my, hands in a lot of different things because of the why. Mm-hmm. And so,
I totally relate to that.
and it's exciting, new information and how does it relate? How do, things relate? I try to relate or connect dots.
Yeah.
Yeah.
And so it's really important for me because things are very connected, more connected, I think, than medicine really appreciates.
Yes, absolutely.
So.
Are you familiar with bone score? You heard of that?
Mm-mm.
This is an invention that came from UCSB, and it was one of the professors there that was looking at bone health, and I'm reminded of this because of the rhythms of bone growth, and this person was looking for a better way to assess bone damage or bone weakness, and so he developed he talked to orthopedic surgeons, said, how do you assess bone? Before you put a screw in it or a plate in it to repair the bone, how do you assess it? And he said, well, I bang on it. I tap on it. What is this? Is this a solid piece of wood or not? And so he realized that wasn't really clinically appropriate to operate on every patient to see how good their bones were, but developed this procedure that basically under local anesthesia in the office, a 10-minute procedure of hitting the bone with a probe and measuring the hardness of the bone. And that is now an FDA-approved test. It's only available, to my knowledge, in Santa Barbara and in the Netherlands. It is being introduced in the Mayo Clinic currently. But we've been doing it for a year and a half or so in the office, and it's essentially painless. The test itself takes about 15 seconds, and we get a result right away. And because of the data that's been created by all of the studies that have been done, all of the people that have been using it, we're getting more and more information as to what we'll be able to just put it on instead of on a scale of 0 to 100 of how hard this bone is, we're now being able to look at this more precisely and see, okay, what is the impact that this bone needs to have to make it fracture? So is this abnormal? Is this okay for a certain patient or other? Anyway, it's something that we're doing right now, and it's I think it's fascinating.
It is fascinating. Can I ask a question? What bone do you use?
Tibia.
Of course. Okay.
It's the only one that's close enough to the surface.
Under the skin.
Yeah.
And then do they correlate bone density with this at all?
Well, we're doing that. I mean, almost every patient I'm doing, I have some other bone, I have a bone density score as well. And usually if I have patients that have a concerning bone density, then I will really twist their arm to do this test, because I think this is more reliable. But at the moment, it's still data gathering.
Got it. And can you tell a difference of women who are on like hormone replacement versus the other bisphosphonates?
We don't have any. We have that data in that we know which patients are on medication and which are not. I've had a few patients who I've tested 6 months after one who've been put on hormone replacement therapy or some physical therapy program of weight bearing and seeing an improvement. Because the nice thing about this test is it's very sensitive, it's reproducible, and it's sensitive. And so it's exciting to be involved with that. I talked to the company way back when, before COVID occurred and when they were still trying to get FDA approval. And then after COVID was done, it was available, so we've been doing that. So
Wonderful.
It's been really good. Cool. And okay, one last thing. You're a dancer.
Shh.
No, I love this fun fact about you.
Yes, I've been dancing. I would have never guessed this in my life. I started dancing, performing about 10 years ago. Mm-hmm. Just
What type of dance?
Oh my gosh, I dance with a little performance group. Dance with Haru, but he was a UCSB student, a senior, and he was doing aerobics classes when he was in his senior year, and it was just, his classes were so fun, and he was himself as a professional dancer. Mm-hmm. So he started his own group here, and a lot of it just were like middle-aged women, and we just had a lot of fun. It became like my playtime with my friends who get dressed up and do fun things. I think because as a kid myself, I mean, I went to high school, college, and right into medical school. I mean, I just worked my butt off.
Right.
And, then in my...
Didn't play very much.
Didn't play very much. And then here in my 50s, it's been one of the most wonderful things that has happened to me.
That's fantastic.
So, yeah.
Julie, thank you very much for being on the podcast.
Thank you for having me. I appreciate it.
Welcome. You can always DM the Vagina Doctor Instagram with any questions or topics you'd like to learn more about, or email us. See you in the next episode. The Vagina Doctor Podcast. It all starts here.